Welcome to another EduMed video, and in this video we'll be doing the second part of the respiratory management of COVID-19 patients as outlined in the NHS England critical care guidelines that were published on the 8th of April. It's a really useful set of guidelines and it's worth having a read through of it. Obviously things are updating as time goes on, but this document is being updated simultaneously with any big updates that are happening with the management of these patients, but it gives quite a good overview of the main issues to consider, especially on critical care, but also on general wards. In this video, we'll be talking a little bit about the intubation of these patients, mechanical ventilation with a ventilator strategy, the ARDS management of patients with the H phenotype of the disease, pruning, the place for tracheostomies, thinking about NIV for weaning, ECMO, and what are these aerosol generating procedures that do present high risk to both surrounding patients and also staff members. And finally, a little bit about steroids and this emerging phenomenon of patients having secondary aspergillus infections, and we're certainly seeing a few of those, especially reported in China. In terms of intubation, there's quite a lot of guidelines out there, and I'd suggest using this particular website. It's a fantastic repository of information about the intensive care management of patients with coronavirus and goes through how to intubate these patients. The key things are that it's an aerosol generating procedure. The person intubating should be experienced and ideally using some form of video laryngoscopy so that they get the tube in first time, and also they don't have to get too close to the patient and therefore increase the risk of high doses of viral particles coming into contact with the intubator. In a lot of hospitals in the UK, they've developed specialist intubating teams, or the merit teams, and they seem to work really well because they're well drilled, well used to doing it, and can do it all quite slickly, which is exactly what you want in these patients who are often quite unwell, have very little physiological reserve, and also it's a procedure that poses quite high risk to everyone around the area. In terms of mechanical ventilation, a key point that we need to highlight is that there should be an antimicrobial filter that's on the expiratory limb of the ventilator. And this is especially important if you've got patients who are on transport ventilators. Usually the easiest way to do this is to attach a heat and moisture exchange filter, or an HME, onto the extension part that attaches to the endotracheal tube. So all the gas that goes in to the patient goes through the HME, and all the gas that comes out also goes through the HME, and it can act as a block for viral particles. Really vitally important to highlight is that these filters are a potential risk because they can fill up with both water and with secretions, and by doing so you'll get a slow increase in the resistance in the system until you just stop ventilating the patient altogether. So it's vitally important that if that is the case, you change those filters. But again, if you open up the circuit without the HME there, you're potentially exposing patients to the surroundings to lots of viral particles, and so always clamp the tube if you remove the HME. With HMEs, you also get a lot of build-up of secretions, and these can block the tracheal tubes. And certainly we've seen a lot of patients with lots of crusting of the tracheal tubes when we take them out at extubation. And I'm sure there'll probably be patients who end up blocking off their tracheal tubes simply through having dry circuits with HMEs. Interestingly, NHS England suggests that we regularly nebulize saline and mucolytics, and this may help to loosen up those secretions in the chest. The slight problem with this is that you can end up flooding the endotracheal tube and also the filters, the HME filters that we have, and by doing that you can again cause problems with expiration and inspiration, and lead to ventilatory failure. So always think about the patency of the endotracheal tube and of the filter and the tubing in between. If there's any doubts, we need to change them. What's been really great in intensive care over the last 10 or 15 years is that we've used inline suction systems. And the best thing about this is that you don't have to open up the circuit to pass a suction catheter down the endotracheal tube. Instead, it's built into the angle piece of the endotracheal tube, and therefore you don't aerosolize by breaking that system every time you want to suction the patient. There are specific things to be worried about with using anaesthetic machines in intensive care. I won't go through the things that are listed here in the guidelines, and rather I would refer you to a video that I did on the things to be aware of when ventilating intensive care patients on anaesthetic machines, and there really are important things that can potentially cause huge amounts of damage to patients and potentially even death of patients if they're not appreciated. So I'd highly recommend going and watching that video to be well versed in the potential problems that could happen. I think in general, in intensive care, hand bagging is a bad thing and we should avoid it. Not just because you can break the circuit and therefore potentially aerosolize a lot of virus, but also we can inadvertently give quite high pressures and high volumes to what's quite fragile inflamed lung. Not just in COVID, but in other intensive care patients as well. And that barotrauma and volutrauma can potentially be quite deleterious to the recovery of the patient. So always avoid hand bagging or manual ventilation of patients if you can. If you do have to break the circuit, always clamp and make sure that the ventilator is in the pause or standby setting. If you don't do that, you will just blow whole loads of gas, which is laden with virus, all over the room. So always plan any tube disconnections, clamp the tracheal tube and pause the ventilator before breaking the circuit. This can be really important if you're replacing the antimicrobial filter, and in a lot of circuits it's suggested that every 24 hours it's changed at a minimum. If you're proning or deproning patients, you sometimes have to disconnect the circuit. I must be honest with you, I never disconnect the circuit when proning or deproning, but you always have a very experienced airway trained doctor at the head end when doing it to make sure that the tube doesn't either move out, you don't get an extubation, or it doesn't push in too far during either the proning or the deproning period. And of course, when inserting a bronchoscope, it'll almost always have to be opening the circuit and as such treated as an aerosol generating procedure. But pause the ventilator. Obviously you can't clamp the tracheal tube in this case because you need to pass the bronchoscope through it. Now, it's often important just to go over the management of the pneumonitis patients. And often in the first few days of severe COVID infection requiring critical care, you find that a lot of patients have this so-called L phenotype of COVID. I've gone through that in another video, so please check out my channel to go through that in a lot more detail. But what we find is that the compliance is often normal, and so there's an argument that these patients may not need recruitment. Now, I'm on the fence as to whether that's true or not. I still think that atelected trauma is a big thing and something that we should avoid. And even in the patient with good compliance, a lot of alveoli may still be collapsed. And so recruitment is still probably a good thing. And I generally have quite a low threshold for APRV, which I think is quite a comfortable mode of ventilation for patients if they want to spontaneously breathe, if you're having trouble with sedating them. And also I think it's really useful at recruiting things up over a matter of hours. And sometimes it can take 6 to 12 hours before you see the improvements when you're using APRV. But theoretically, these patients may not need as much recruitment, and as such, they may not need as high a PEEP as you might often see in the ARDS literature. I think lung protective ventilation is vital, and so using driving pressure targets of less than 15 centimeters of water is a no-brainer. Driving pressure is the plateau pressure, so if you're in volume control, the plateau pressure, or if you're in pressure control modes of ventilation, the PINSP minus the PEEP. So for example, if you've got a PEEP of 5, the maximum P high or plateau pressure that you should be aiming for these patients is 20. And so 20 minus 5 would be 15. So always be careful if you're using a P high or the PINSP that's higher than 15 above the PEEP. I think neuromuscular blockade is really important, especially in this high volume group of patients, which is the COVID patients. If you've got lots and lots of patients on the ventilator who may be desynchronous, some may be desynchronous, I think the easiest thing to do is to give them neuromuscular blockades. Nothing in intensive care comes for free, and of course by doing so you do run the risk later on in these patients being quite profoundly weak. But I think if you've got dysynchrony, until you've gone through the whole process of managing what the dysynchrony is due to, it's easiest and probably safest for the patient to give them a neuromuscular blockade. Sometimes patients with really high spontaneous minute ventilations, and we do see this with some of our COVID patients, you might need to just neuromuscularly block them, paralyze them, and therefore take over ventilation and prevent the very big intrapleural pressure swings that can be quite damaging to the lung. I think pulmonary vasodilators are helpful, and I've certainly used it a few times in these patients. Inhaled nitric oxide does work, but it's quite a palaver to set up, and you need to have various different bits and pieces to be able to use it properly, and it's quite expensive. And unfortunately, these patients can have quite bad rebound pulmonary hypertensions. So I tend to use a nebulized epoprostenol more, and it does seem to be useful, and it improves your VQ matching, and therefore can get quite massive increases in your partial pressure of oxygen, your saturations, and therefore you can reduce down your FiO2. So it is helpful. Consider it where possible. Some of the patients who come in with that initial L phenotype then progress on to the H phenotype. That can be very quickly, or it can take a week or so to get into that H phenotype. But when they do, the compliance is much lower, and these patients behave a little bit more like the typical ARDS patients that we're all used to. And so giving higher PEEPs, giving recruitment manoeuvres, getting open those alveoli are really important. Again, lung protective ventilation, the 6 to 8 ml per kilos, using a driving pressure of less than 15 centimeters of water are vital, and also not flooding the lungs with lots of fluids. Proning is fantastic in these patients and seems to work really well in the majority of patients with COVID, and so early proning is important, and the ProSEVA trials really do show that you can reduce both morbidity and mortality by early proning of these patients. Continuous neuromuscular blockade may be required in these patients, and they suggest a bolus rather than an infusion. My personal preference, if I've got lots of patients being proned and lots of junior nurses looking after them, is I find that an infusion is a little bit more reliable and therefore may be better. Now, the evidence for using boluses is that maybe it causes less neuromuscular wasting, critical care neuromyopathies, and may provide a more profound neuromuscular blockade. But if things get delayed, you may well have patients coughing in the prone position and therefore potentially extubating themselves. So for safety's sake, I tend to use the infusions myself, but the guidelines suggest bolus. Lung recruiting manoeuvres such as high PEEP escalations. I must admit, now that I'm au fait with APRV, I find that APRV is a lot safer and actually a lot more comfortable patients if they want to spontaneously breathe. And so I tend to use APRV as both my recruitment manoeuvre and also my primary mode of ventilation for a lot of patients who are invasively ventilated on relatively high fractional inspired concentrations of oxygen. Lung ultrasound is making its name at the moment, and there is some suggest that if there's lots of B lines, you may need to give them slightly higher PEEPs. They may be PEEP responsive. To be honest, I find that most patients do require a bit of recruitment, even if they look like they don't on ultrasound or on CT or on chest x-ray. And that's because all patients have some degree of atelectasis, and that can be improved by just providing a bit of continuous positive airway pressure. And like I say, APRV is my mode of choice really, because I think it causes a lot less alveolar instability, reduces the risk of atelected trauma, and therefore may well be better for the lung in the longer term. Pruning does seem to be really useful, not just with those patients with pneumonitis and ARDS, but just in general. And there's a whole range of reasons why pruning may work. And I've done a whole video on pruning and the biomechanics of it and how it improves oxygenation and CO2 clearance. So please check that out if you want more information. The recommended 16 hours is actually quite reasonable, and it allows us to prone and deprone at the start and end of a normal 8-hour working day, so it was done for practical reasons. Generally speaking, the longer you keep a patient prone, the better, but for nursing needs and for changing lines and doing other things, I think turning them over every so often is actually quite useful, and they can get quite nasty sores, pressure sores, and also they can get quite bad facial edema if they're kept prone for long periods of time. And one key thing, if you are proning patients, always make sure that you put them into a reverse Trendelenburg, i.e. the head is above the level of the heart. It'll drain away a lot of the lymph and therefore reduce a lot of that facial swelling. Because if you get an accidental extubation of these patients, it is a nightmare trying to intubate a patient with laryngeal edema. The guidelines themselves talk about having proning teams, and actually a lot of trusts have really taken this on board, and a lot of the non-intensive care doctors, people like neurosurgeons, orthopedic surgeons who are used to proning patients, have formed part of these teams, and I think they're a fantastic utility to have and something that should be developed in every hospital who looks after COVID positive patients. Tracheostomies are contentious. There's quite a lot of information available, and I'd recommend reading the guidelines themselves because they give hyperlinks to lots of useful resources. I think you have to think about when to put a tracheostomy in, and the honest answer for me is I have no idea when the right time is. But certainly I'm finding that a lot of these patients are requiring prolonged ventilator weans. A lot of them, especially the biphasic patients who initially present with an L phenotype and then progress after a few weeks into an H phenotype, they do seem to fail extubation quite a lot, and so tracheostomy may be the best way to try and wean them off mechanical ventilation. Also, as we're starting to run out of drugs like sedatives, at least having a tracheostomy in place means that we can reduce the amount of sedation that's needed, and therefore be able to manage our stockpiles of sedative agents better. Patients are often requiring less nursing needs if they've got a tracheostomy in with a trache mask as opposed to being invasively ventilated. So I think there's a lot of pros for having a tracheostomy, but when to put it in, the the risk of aerosolization of the virus when putting in a tracheostomy, and the degree of failure, respiratory failure, the hypoxia, may all preclude you being able to put in a tracheostomy early on in the clinical course of the patient, and often after a few weeks is probably better. The TrackMan trial suggests that early versus late tracheostomy, there doesn't seem to be much difference. And the other more practical thing is pruning patients with a tracheostomy always ends up being a little bit more difficult than those with endotracheal tubes. So if the patient's looking like they're needing pruning, I tend not to put a tracheostomy in until they've been very stable for a couple of days, if not longer, and 24 hours deproned. Now, the guidelines suggest the use of NIV machines for weaning patients and extubating them onto NIV or CPAP. My general feeling on this is I don't like doing it. And the reason I don't like doing it is that a lot of patients seem to be failing extubation for laryngeal edema or vocal cord dysfunctions and things like this. And CPAP and NIV are just really a bridge. If I think they're going to need a bit of help with NIV or CPAP, they're probably not ready to be extubated. The COVID group of patients seem to be a group of patients where they seem to relapse and require reintubation fairly commonly. As such, I will only really extubate these patients when I'm really happy that they're absolutely fine, which generally means that they're beyond the window for an extubation onto NIV or CPAP, which we often do to expedite recovery. Because these patients have such a fluctuant clinical course, I don't think it's reasonable, wise to extubate these patients onto NIV or CPAP. I'd rather extubate them onto simple face mask oxygen, and if they're not ready to do that, then keep them intubated. That's my general feeling. However, the role for NIV and CPAP in a broader sense is still being really understood. ECMO, thankfully, hasn't seemed to be as necessary as we were first worried that it would be. And the ECMO services themselves haven't really been inundated at this point. There are lots of plans out there, and there are lots of things if patients do need to be referred for ECMO, but they're all on the referral platform, and it's worth speaking to your local severe respiratory failure centre early if you think that this patient is going towards requiring ECMO. Aerosol generating procedures is something that people have been debating quite a lot as to what constitutes an aerosol generating procedure. I think from an intensive care standpoint, both intubation and extubation are really important, as is face mask ventilation. And as a general rule, I tend to say do not face mask ventilate these patients. Pre-oxygenate them appropriately with 5 minutes of oxygen, and then do a rapid sequence induction and just intubate them. Any circuit disconnection will potentially cause an aerosolization, as will bronchoscopies and tracheostomies. And a lot of physiotherapy interventions, such as birding patients, can potentially aerosolize quite a lot of virus, so it has to be done quite carefully. There's a huge list of things on the Public Health England website, and there's also a lot of guidance on the appropriate level of PPE. I'm not going to go through that in this talk. What is interesting is that they do consider nebulizers not to be an aerosol generating procedure. But I think in critical care that probably is definitely true, because we can do it within a closed ventilator circuit, and so the risk of aerosolization of virus is low to none. On the wards, they say that it's not. My personal preference is to put a surgical face mask over the nebulizer as well, just to get rid of some of those big droplets that may be being breathed in and out of the patient. Steroids are interesting, and there is an indication that there is a hyperinflammatory state in patients who deteriorate with COVID-19. The current guidelines from Public Health England is that routine use of high-dose steroids is not advised, and that's due to the risk of prolonged viral shedding, and definitely we're seeing some bacterial superinfection. Now, what the right immunomodulatory drug is up for debate. There's a huge number of different, more targeted drugs that may be useful. Honestly, we just don't have the data yet to know what to do. Having said that, we sometimes use steroids in patients who are hypotensive, resistant to high-dose vasopressor therapy. This is usually in the form of hydrocortisone that's given either as an infusion or as boluses throughout the day. That's still indicated, and that's treating a totally different pathophysiology than the COVID necessarily itself. But high-dose steroids, especially things like methylprednisolone, although used fairly widely in other countries, is not being recommended by Public Health England. I think it's really important in this guidelines that they touch upon Aspergillus, because certainly it's something that I'm worried about and something I've seen in the Chinese literature, definitely. Patients do seem to be getting a lot of Aspergillus co-infections, and they usually happen in those patients over 7 days. I think the old mantra that if you've got a persistent raised inflammatory markers and fevers and you're on antibiotics, always think about a fungus, and I think Aspergillus is important to know about. There are a number of things that can contribute to developing an Aspergillus infection, immunosuppression being one of them. And that's not just high-dose steroids, but those patients who have immunosuppression for other underlying conditions such as malignancies or autoimmune conditions. It's really important to have a low threshold for thinking about aspergillosis. Any patient who seems to be deteriorating despite you giving them appropriate antibiotics and appropriate respiratory and cardiovascular support, think about it. Anybody who's developing progressive radiological changes, always have a low threshold for thinking about aspergillus and send the screening off as appropriate. There are a number of local protocols, and just follow that essentially, but just always think about aspergillus. So just by way of summary, I think it's really important to be aware of the anaesthetic machines and their limitations. Please go and have a look at my video on that. Lower PEEPs may be appropriate for patients. I think actually it's going to be debatable, and personally I think reducing the amount of atelectic trauma is important, and so APRV, even if it's on a low setting, is, in my personal opinion, just as good, if not better, but certainly the advocates here are for lower PEEP strategies. For H phenotype of COVID, it's probably worth using an ARD similar type of strategy, and I think for both L and H phenotypes, using driving pressures less than 15 centimetres of water and using an appropriate PEEP level with peak or plateau pressures less than 30 is important. Tracheostomies have a debatable place, and honest truth is we just don't know when the right time to do that is. And weaning onto NIV, although suggested, again, personally, I'm very reluctant to do this because of the high reintubation rate of these patients. I think if they're not ready to be extubated onto face mask oxygen, they're probably not ready to be extubated, but that's my personal opinion. And I think, as always in intensive care, never forget fungi. Always think about it in a patient who's clinically deteriorating, who's immunosuppressed, or has been in intensive care for a long period of time. It's something that we shouldn't be missing. I hope that's been useful, and I'll be going through the other parts of the critical care guidelines as published by Public Health England. Thank you very much.